Welcome to our video on bacterial diarrhea. Let's get started. In this video, we will cover the common causative agents of bacterial diarrhea, namely enterotoxogenic and enterohemorrhagic E. coli, also Shigella, Salmonella, Vibrio cholera, and Campylobacter jejuni. For each condition caused by these bacteria, we will be discussing the definition, pathophys, all the details down to diagnosis and management. So let's start with the definition of enterotoxogenic E. coli. Enterotoxogenic E. coli, just like any other species of E. coli, is a gram-negative, lactose-fermenting, indole-positive rod. And enterotoxogenic E. coli is commonly referred to as ETEC for short. And it's the causative agent of what's known as traveler's diarrhea. ETEC produces two toxins, heat labile and heat stable enterotoxins. Heat labile toxin inactivates adenylate cyclase, increasing cyclic AMP levels in enterocytes. Now, increased cyclic AMP causes excessive chloride and water secretion from the enterocytes and into the gastrointestinal lumen, contributing to diarrhea. Heat stable toxin, on the other hand, activates guanylate cyclase, increasing cyclic GMP levels in enterocytes. Increased cyclic GMP inhibits sodium chloride and water reabsorption from the lumen into the enterocytes, and then that's what contributes to diarrhea with that toxin. An important distinguishing feature of ETEC from the other species of E. coli is that ETEC does not invade gastrointestinal mucosa. Therefore, we do not say that it has inflammation or that it causes inflammation. Let's illustrate how heat labile and heat stable toxins work. Here we have enterocytes lining the gastrointestinal mucosa. Heat labile toxin activates adenylate cyclase, which in turn increases cyclic AMP levels. Increased cyclic AMP in the enterocytes stimulates chloride and water secretion into the lumen. Heat stable toxin, on the other hand, activates guanylate cyclase, which in turn increases cyclic GMP levels. Increased cyclic GMP in the enterocytes inhibits sodium and chloride and water reabsorption, so they're not being reabsorbed from the lumen. So this is how heat labile and heat stable toxins contribute to diarrhea caused by ETEC. ETEC is characterized by fecal oral transmission, and it's prevalent in the regions with inadequate sanitation. Now, ingestion of either contaminated food or water can also result in ETEC infection. Now let's discuss the clinical features of ETEC-induced diarrhea. ETEC infection is also known as the traveler's diarrhea, as we mentioned earlier. It has a short incubation period. It's only about 1 to 3 days. And after that incubation period, the patients experience watery diarrhea. Now, vomiting is less common than diarrhea, but it is possible with traveler's diarrhea. Now, ETEC infection is a self-limiting condition, and it only lasts about 5 days. So you can think of the incubation period as being short, and the actual condition and disease as being short. On to diagnosis now. If we want to definitively diagnose ETEC infection, we should perform stool PCR for the heat labile and heat stable toxin genes. However, in real clinical practice, this test is not routinely performed because the results really don't change the patient's management. Let's finish up our discussion about ETEC by discussing the treatment. Now, the mainstay of therapy for traveler's diarrhea is fluid replacement. If the patient can tolerate oral fluids, then we can administer oral rehydration solution, that is ORS. And that contains electrolytes and glucose to help facilitate sodium and chloride absorption. On the other hand, if the patient cannot tolerate oral fluids, or if he or she is severely dehydrated, then we can actually give IV fluids to help replete volume. Now, antibiotics are rarely used because, as we mentioned on one of the previous slides, traveler's diarrhea is a self-limiting condition, usually resolving within about 5 days. Now we'll discuss enterohemorrhagic E. coli, also known as EHEC. Here's a reminder of the sequence we will follow in describing diseases caused by EHEC, starting with definition. EHEC, just like any other species of E. coli, is a gram-negative, lactose-fermenting, indole-positive rod, and it's the causative agent of dysentery, that is, bloody diarrhea, and the hemolytic uremic syndrome, also known as HUS. So, enterohemorrhagic E. coli causes more blood than ETEC It has hemorrhagic in the name. O157H7 is the most common serotype of EHEC, and it's implicated as the cause of dysentery and HUS. Now, this serotype produces Shiga-like toxin, also known as verotoxin. Now, this Shiga-like toxin is an exotoxin similar to the mechanism of Shigella, which makes sense. If you call it a Shiga-like toxin, it makes sense that it would be a lot like the Shigella toxin. So both the Shiga-like toxin and this EHEC exotoxin inactivates the 60S ribosomal subunit, which inhibits protein synthesis. Now, as for the hemolytic uremic syndrome, this is caused by microthrombi formation. So you get these little microthrombi on the endothelium. And those microthrombi are made of platelets, so that consumes platelets. Additionally, red blood cells get sheared when passing through those thrombi. And finally, reduced luminal diameter of the blood vessels causes decreased renal blood flow. The toxin of which bacterium has a similar mechanism to the verotoxin of EHEC? Okay, as we discussed on the previous slide, the verotoxin of EHEC works in a very similar way to the Shiga toxin of Shigella. So it inhibits the 60S ribosomal subunit, and there's decreased protein synthesis in the human cells. EHEC is most commonly transmitted via undercooked meat, such as raw beef in a hamburger. It can also be transmitted via raw vegetables. Now, risk factors and diseases caused by EHEC are commonly remembered by the following mnemonic. EHEC. It's associated with hemorrhage and hamburgers and hemolytic uremic syndrome, all of which start with H. Now let's discuss the clinical features of EHEC-induced diseases. Since we're talking about infection, fever is one of the most prominent clinical features, and it's pretty intuitive. As we already mentioned on one of the previous slides, EHEC causes dysentery, that is, bloody diarrhea. And EHEC itself is a non-invasive organism. The diarrhea is actually caused by verotoxin, not the microbial invasion in the gastrointestinal mucosa. It's the toxin. As for the hemolytic uremic syndrome, it consists of a triad. We say hemolytic anemia, that's 1, acute kidney injury, that's 2, and then thrombocytopenia, 3. Now, since anemia is hemolytic, we will see increased indirect bilirubin and high LDH, as well as low haptoglobin, and you'll see schistocytes on blood smear. As for the renal failure, this is intrinsic acute kidney injury. Therefore, the BUN to creatinine ratio is expected to be less than 15. Finally, a complete blood count will reveal thrombocytopenia. Here you see an example of a peripheral blood smear revealing a schistocyte. Please keep in mind that although schistocytes are seen on the blood smear in hemolytic uremic syndrome, this finding isn't specific for HUS. Schistocytes can be seen in any type of angiopathic hemolytic anemia, for example, TTP and DIC. Now on to the diagnosis. If we want to definitively diagnose EHEC-induced dysentery, we should perform stool PCR for verotoxin. Additionally, we should check for leukocytes in stool to check if the diarrhea is invasive or not. As we mentioned already, EHEC itself is a non-invasive organism, and it's the toxin which causes all the symptoms. To diagnose hemolytic uremic syndrome, we should obtain a CBC to check for anemia and thrombocytopenia. And then you need to check the creatinine and electrolytes to identify renal failure. And then get a blood smear to check for schistocytes. Now we will discuss the treatment strategies of EHEC infections. For dysentery, the mainstay of therapy is IV isotonic fluid replacement. We can use either normal saline or lactated Ringer's solution for this purpose. The point is that you're just giving them fluid, trying to replace it. Antibiotics are usually avoided in both dysentery and HUS because killing EHEC in the gastrointestinal system will release even more verotoxin and actually exacerbate the patient's overall condition. Now, similarly, anti-motility agents, for example, loperamide or diphenoxylate, are also avoided because microbial retention in the gastrointestinal lumen due to the action of an anti-motility agent might exacerbate the patient's condition. So you're not really trying to stop them from having motility in their bowels. Now, finally, if there's a significant renal failure, for example, if they have HUS, then you can start dialysis. Now we will discuss Shigella species. Discussing Shigella-induced diseases will be easy considering that we've already talked about EHEC. However, although there are many similarities between Shigella and EHEC, there are also some subtle but high-yield differences between them. We'll point those out for you. We will use this same sequence when describing diseases caused by Shigella. So let's jump into the definition. Shigella is a gram-negative, lactose non-fermenting rod. And just like EHEC, Shigella can cause dysentery and HUS. Speaking of pathophysiology, the main mechanism of how Shigella causes disease is that it invades the M cells overlying the Peyer's patches in the gastrointestinal mucosa. So those M cells. Now Shigella also produces Shiga toxin, which works just like the verotoxin of EHEC. However, invasion, not the toxin, is the main pathogenic feature of Shigella. So that's the opposite of EHEC. Now Shigella spreads from one cell to another, and it is not characterized by hematogenous dissemination. Now, severity of infection depends on the specific species of Shigella. The most infectious species is Shigella dysenteriae, while the least infectious species is Shigella sonii. Let's illustrate the main mechanism of pathogenicity of Shigella. Here we have enterocytes lining gastrointestinal mucosa. Shigella invades the M cell of the gastrointestinal lumen. Then Shigella is taken up by macrophages, and this initiates a generalized inflammatory state. Now, what's the main difference between pathogenicity of EHEC and Shigella? Well, as we discussed on one of the previous slides, Shigella is an invasive bacterium that produces Shiga-like toxin, while EHEC is a non-invasive bacterium producing verotoxin, or Shiga-like toxin. So just remember, Shigella invades, EHEC does not. Shigella is characterized by fecal-oral transmission, just like EHEC, and it's prevalent in the regions with poor sanitary conditions, which is also fairly intuitive. And it can also be transmitted by contaminated food. Let's help you remember the risk factors for Shigella. They're often remembered using the following mnemonic, the 4 F's, starting with fingers, then flies, and then food, and feces, the 4 F's. Now let's discuss the clinical features of Shigella-induced diseases. Since we're talking about infection, fever is one of the most prominent clinical features. And of course, it causes dysentery, so you'll have bloody diarrhea. And it can also cause hemolytic uremic syndrome. And again, that classic triad is hemolytic anemia, acute kidney injury, and thrombocytopenia. On to diagnosis now. The best way to diagnose shigellosis is to perform a stool culture and antibiotic susceptibility testing. Additionally, we should check for leukocytes in the stool. And those will likely be positive because Shigella is an invasive organism, so it would make sense that there would be this immune response with leukocytes present. To diagnose hemolytic uremic syndrome, we should obtain a complete blood count and check for anemia and thrombocytopenia. And then, of course, do a chemistry panel to identify creatinine and electrolytes, which can help you identify renal failure or acute kidney injury. And then, of course, get a blood smear to check for schistocytes. Now we will discuss the treatment strategies of shigellosis. The mainstay of therapy is fluid replacement. Now, if the patient can tolerate oral fluids, you can just give oral replacement solution. However, if she or he cannot tolerate oral fluids, then we can use IV isotonic fluids. And similar to EHEC, antibiotics and antimotility agents are usually avoided in Shigella infections. However, there are certain circumstances when we do give antibiotics to patients with shigellosis. Specifically, if the patient is immunocompromised or has severe disease with extraintestinal manifestations and bacteremia, we can start antibiotic therapy. Additionally, if the patient is a food handler or a child care provider or they're a nursing home resident, then you actually just want to give antibiotics to prevent the spread of Shigella. Now we will discuss Salmonella species. Here's a reminder of the sequence that will follow. Let's start with the definition of Salmonella infections. Salmonella is a gram-negative motile lactose non-fermenting rod. Salmonella typhi causes typhoid fever, while non-typhoidal Salmonella species cause gastroenteritis. In terms of pathophysiology, Salmonella is actually pretty similar to Shigella. Namely, the main mechanism of how Salmonella causes either typhoid fever or gastroenteritis is the invasion of M cells. Additionally, it has endotoxin similar to any other gram-negative bacteria. Now, what distinguishes Salmonella from Shigella is that Salmonella does not produce an exotoxin, and it's characterized by hematogenous rather than cell-to-cell spread. If you remember, Shigella invades the M cells and then travels from cell to cell. Salmonella does not. It travels through the blood hematogenously. Now finally, Salmonella typhi can colonize the patient's gallbladder even after the resolution of typhoid fever. Now, Salmonella is characterized by fecal-oral transmission, and it's prevalent in regions with poor sanitary conditions. Now, Salmonella is mostly transmitted via contaminated food, such as undercooked poultry and eggs. And since Salmonella species are acid labile, increased gastric pH due to proton pump inhibitors is actually a risk factor for infection. Because if you're making that gastric pH more alkalotic, then it's more likely that the Salmonella species will survive. So, when you give patients PPIs, they are more likely to get Salmonella. Now, non-typhoidal Salmonella specifically can also be transmitted via pets like turtles and lizards. In other words, all of the Salmonella species you can think of being transmitted through poultry and eggs, but then when you want to think about non-typhoidal Salmonella, you can think about pets like turtles and lizards. Now let's discuss the clinical features. We'll start with typhoid fever. Now, typhoid fever is characterized by pink macular rash on the abdomen, sometimes referred to as rose spots. And the patient can often have abdominal pain. And the pulse temperature dissociation is often common. Let's discuss this. This means that there's a rise in pulse that is not proportional to the rise in temperature. In other words, the patient might have a temperature of 39 degrees Celsius, and the heart rate is 65 beats per minute. Generally, whenever the body temperature rises, like if they're infected, the heart will try to increase the rate of cardiac output. So it'll increase the heart rate to meet the oxygen demand of the inflamed tissues. So you expect them both to rise. This compensatory response is impaired in typhoid fever. So a pulse temperature dissociation. As a side note, pulse temperature dissociation is also seen in Legionella infections. Now, typhoid fever usually starts with constipation, and then it's followed by diarrhea. Finally, the patient might develop gastrointestinal ulcerations and hemorrhage. Shifting gears now, let's briefly review gastroenteritis that's caused by the non-typhoidal Salmonella species. This infection is mostly characterized by non-bloody diarrhea, although it can sometimes be bloody too. Here we see the rose spots. You can see them there on the anterior chest wall, which is characteristic of typhoid fever. On to diagnosis now. Now, the clinical features, like those rose spots on the abdomen, as well as constipation followed by diarrhea, are pretty helpful in diagnosing typhoid fever. However, Salmonella gastroenteritis does not have specific symptoms. Therefore, clinical features of the infection are less useful in this case. Now, whenever we suspect Salmonella infection, we should perform a stool culture in order to isolate the pathogen. If you specifically suspect typhoid fever, then blood cultures should also be obtained, because typhoid fever is a systemic illness. Now, stool white blood cell count is elevated in invasive forms of diarrhea, such as Salmonella gastroenteritis, and that's very similar to EHEC, which is also invasive in the enterocytes. So, whenever there's enterocyte invasion of the bacteria, then you can expect a white blood cell count to be high in the stool. Now we will discuss the treatment strategies of Salmonella infections. The mainstay of therapy for salmonellosis is fluid replacement. If the patient can tolerate oral fluids, of course you can give oral replacement solutions. However, if they can't, give IV fluids. Now, typhoid fever is usually treated with ciprofloxacin or ceftriaxone. However, antibiotics are usually avoided in Salmonella gastroenteritis. So, non-typhoid Salmonella, avoid antibiotics. But if they have typhoid fever, give antibiotics. Now, there are certain circumstances in which you do give antibiotics, even with the gastroenteritis variety. Specifically, if the patient is immunocompromised, if it's an infant, or it's an adult over 50 years of age. And of course, if they have a severe infection characterized by a prolonged fever, or hypotension, or a leukemoid reaction, you can also start antibiotics. A 27-year-old male comes to the physician due to recent onset of loose stools starting 4 days ago. He denies vomiting. He attended a birthday party 6 days ago where he tasted chicken salad. Past medical history is significant for HIV infection diagnosed 7 years ago. His vital signs are normal except for a temperature of 38 degrees Celsius. Stool cultures come back and they're positive for salmonella. He is given ciprofloxacin. Which characteristic of this patient best justifies the use of antibiotics for his infection? So this patient presents with Salmonella gastroenteritis. Now, as we discussed on the previous slide, antibiotics are not routinely used in Salmonella gastrointestinal infection. However, there are certain circumstances in which we can use antibiotics. Once again, those are immunocompromised patients, young or elderly patients, and those patients with severe disease. And this patient has a 7-year history of HIV, which makes him immunocompromised and eligible for antibiotic therapy. Let's move on to Vibrio cholerae. Once again, we'll go through the same sequence, starting with the definition. Vibrio cholera is a gram-negative, motile, comma-shaped rod. As we just mentioned on the previous slide, it's the causative agent of cholera. So let's talk about the pathophysiology. Well, Vibrio cholerae produces cholera toxin, which ADP ribosylates the stimulatory G protein activating adenylate cyclase. So that might be a lot to remember. In fact, those details can be easily memorized using our image mnemonic on cholera within the microbiology chapter. So please feel free to review back to that if you'd like. But the net result is shown here. Overactivation of adenylate cyclase itself causes increased cyclic AMP production. So focus on the cyclic AMP. Cyclic AMP opens up the apical chloride channels on the enterocytes and causes increased chloride and water secretion into the gastrointestinal lumen. So naturally, this would result in a high-volume secretory diarrhea. Cholera is prevalent in the regions with poor sanitary conditions, and it can be transmitted by ingestion of contaminated water and food. Oftentimes, you'll hear shellfish. Now, since Vibrio cholerae is acid labile, increased gastric pH due to proton pump inhibitors can also be a risk factor for infection. So this is very similar to the organism we discussed previously. If you're making the gastric pH higher, more alkalotic, you're actually making it more suitable for Vibrio cholerae. So keep that in mind when prescribing PPIs. Now let's discuss the clinical features of cholera. As we already mentioned on one of the previous slides, cholera causes a very high volume, non-bloody diarrhea. Now, stool of cholera patients usually contains sloughed gastrointestinal epithelial cells. There may be flecks of mucus and bacteria, and all those together give this appearance of rice water. So often we'll hear the term rice water stools. Now, high volume diarrhea, of course, causes dehydration. So clinically, you might see signs of dehydration, such as decreased skin turgor and even sunken eyes. Here's an image of a dehydrated patient with sunken eyes and decreased skin turgor. You can especially see that on the hands. Diagnosis of cholera is mostly clinical. If we want to isolate the organism for definitive diagnosis, you can perform a stool culture. However, that's not routinely done. Calculating a stool osmolar gap is particularly helpful to distinguish between osmotic and secretory types of diarrhea. Often something you do when you're dealing with a non-bloody diarrhea, you want to know the cause, or how to categorize it even, so that osmolar gap can help you. Now, as we mentioned before, cholera is a secretory type of diarrhea, so it will have a stool osmolar gap of less than 50. Now let's discuss the treatment of cholera. The mainstay of therapy for cholera is fluid replacement. And as always, try oral rehydration first, but if the patient can't tolerate it or they're severely dehydrated, you can actually just jump right to IV fluids. Now, since cholera is a self-limiting infection, antibiotics are usually not given. However, if it is given, then the preferred classes of antibiotics include tetracyclines, macrolides, or fluoroquinolones. Let's finish up by talking about Campylobacter jejuni. And here's the overview slide, and we'll jump right into the definition. Campylobacter jejuni is a gram-negative motile, or S-shaped rod, and is the most common cause of bloody diarrhea. So let's talk about the pathophysiology. Campylobacter jejuni causes gastrointestinal mucosal invasion. and that's the main mechanism of its pathogenicity. It does have an endotoxin, just like all the other gram-negative bacteria, but it does not produce an exotoxin. Now, Campylobacter jejuni is characterized by a fecal-oral transmission, and it's commonly transmitted via contaminated meat and unpasteurized milk. And if you're making contact with an infected animal, you can also get it. Those animals include cats, dogs, and pigs. Now let's discuss the clinical features. So, Campylobacter is characterized by a high fever and bloody diarrhea. And interestingly, that bloody diarrhea has mucus in it. Also, unlike any of the other diarrheas that we've discussed in this lecture, Campylobacter jejuni can precipitate Guillain-Barré syndrome, or reactive arthritis. On to diagnosis now. Diagnosing Campylobacter jejuni usually requires a stool culture to isolate the organism, as well as a stool white blood cell count. And that's to help you confirm that this is an invasive diarrhea. And what did we say was common to all of the invasive bacterial causes of gastroenteritis? They usually have a white blood cell count that's high in the stool. Now we will discuss the treatment strategies. Now, the mainstay of treatment is fluid replacement. That's usually the go-to, if you've noticed that pattern. Now, if the patient can tolerate oral fluids, then you should give them oral replacement solution. If they can't, or they're severely dehydrated, then go to IV fluids. Now, antibiotics and anti-motility agents are usually avoided due to the same reasons that we discussed previously. However, there are certain circumstances that you do give antibiotics, preferably azithromycin or fluoroquinolones. Now, specifically, if the patient is immunocompromised, elderly, or pregnant, or has severe disease with a high fever, or they have extra-intestinal manifestations, or a prolonged course, so greater than a week, you can start antibiotic therapy. Now let's do a board-style question to apply what you've learned. A 35-year-old female comes to the physician reporting diarrhea lasting 1 week. She returned from her trip to Africa 4 weeks ago. After arrival, she started feeling constipated. However, 1 week ago, she started having 6 to 7 non-bloody bowel movements per day, with yellow-greenish stools. Past medical history is significant for systemic lupus erythematosus, treated with prednisone. Her vital signs include a temperature of 40 degrees Celsius, a blood pressure of 100/80, a heart rate of 70, and a respiratory rate of 18. Physical exam reveals pink macular rash on the patient's abdomen. Which of the following is the best treatment option for this patient's condition? A. Ciprofloxacin, B. Ceftriaxone, C. TMP SMX, trimethoprim sulfamethoxazole, or D. Vancomycin. First, we should make a diagnosis of this patient's condition. She recently returned from her trip to Africa, after which she started having constipation, followed by non-bloody, yellowish-green diarrhea. Now, she has a pulse temperature dissociation, if you noticed. She's got the fever of 40 degrees Celsius, it's high, but her heart rate is only 70 beats per minute. And the physical exam reveals a pink macular rash on her abdomen. All these findings are consistent with the diagnosis of typhoid fever. So then, the question really is focused on the treatment of typhoid fever. And as we discussed in our lecture, typhoid fever is treated with ceftriaxone or fluoroquinolones. However, we see both of these antibiotics as separate options. So how do we choose between them? So here's a super useful test-taking tip for you. When two options list two correct treatment options, always look for some contraindication to either of those medications in the question stem. In this case, the patient has systemic lupus erythematosus treated with prednisone. Now, corticosteroids are known to weaken the tendons, increasing risk for tendon rupture. And fluoroquinolones, including ciprofloxacin, also increase that risk of tendon rupture. So you might want to avoid ciprofloxacin in favor of ceftriaxone. So the best treatment option is choice B, ceftriaxone. Now, option C, TMP SMX, is incorrect because it is not routinely used for treatment of typhoid fever. Now, option D, vancomycin, covers only gram-positive bacteria, and Salmonella typhi is gram-negative. So vancomycin is incorrect. And that concludes our lecture on bacterial diarrhea.